The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Before we get started, I'd like to introduce our speaker. Gail Williams, MD, is a professor for the University of Louisville Department of Pediatrics. She's a board-certified developmental behavioral pediatrician and works in a multidisciplinary setting, seeing children of all ages with such concerns as autism, learning disabilities, ADHD, Tourette syndrome, and intellectual disability. Dr. Williams also conducts a biomedical clinic at the University of Louisville Autism Center one day weekly. While her primary responsibilities are clinical, she also engages in clinical research and has authored several articles on autism and other developmental topics. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. And now I'm going to turn it over to Dr. Williams.
Well, hello. It's really a pleasure to be able to speak with you today on the topic of sleep problems associated with autism spectrum disorders. I've worked with children with ASD for about 20 years now, both in diagnosis and treatment. And certainly sleep problems are among the most recurring issues that I see in the children and families that I work with. Learning to sleep through the night is something that all children must do, but it's often a much more difficult process for children with autism spectrum disorders, perhaps in large part due to the underlying deficits that we see in autism, namely the social communication deficits and the insistence on sameness and routine. Impaired sleep can have a tremendous impact on both children and their families. And with this presentation, I'm hoping to provide an overview of some of the sleep concerns in autism, as well as the perhaps neurobiologic basis for some of these problems, what we do as far as diagnosis, and certainly a large emphasis on some treatment strategies that are available. I'm starting with these two quotes because I think they really nicely summarize the need for sleep. We recognize that sleep is not only important for our physical well-being, but for our emotional and overall well-being as well. And these two quotes point to that fact, that if we don't have good sleep, we lose our motivation. We are not as good in learning. We are not as creative as we might other be. Our sense of humor suffers as well. So it really is important to have adequate sleep. And I like this quote too because I think it points to the fact that sleep deprivation results in a lack of self-regulation. We no longer are the mature, rational adults that we want to be, and instead become like toddlers who want what they want right now and are going to throw a temper tantrum if they don't get it. Just to touch base on the basic biology of sleep. Sleep is governed by two biological systems. There's sleep-wake homeostasis, which is really the drive to sleep, and that increases the longer that we are forced to stay awake. Whereas circadian rhythms are our internal clocks that are regulated by light and other factors and keep us either in a sleepy state or an alert state, depending on what our internal clock is telling us. It's also important to be aware that there are different patterns of sleep and stages of sleep throughout the night. Rapid eye movement sleep is really an active sleep phase, during which there is more irregular breathing and irregular heart rate. The eyes tend to move back and forth, but there are no real body movement. This is the stage that most dreaming occurs in. whereas non-REM sleep has several stages. During stages 1 and 2, when we're drifting off to sleep, we can often be easily wakened. Whereas during stages 3 and 4, there is very deep sleep, where you would have difficulty awakening someone, and the muscles are quite relaxed. This is just a picture of the stages of sleep during the night. And as you can see, most of the sleep for adults is spent in the non-REM phase. However, this is something that really changes over time. Infants actually spend about half of their sleep in the REM sleep stages, but that decreases until only about 20% of sleep is REM sleep in adolescents and adults. At least one study has shown that children with autism spectrum disorders seem to have a markedly decreased percentage of time in REM sleep. And we'll talk a little bit more about the significance of that as we go along. So this is a picture of just exactly what we were talking about just then. Again, infants spend about half their time in REM sleep, and then that kind of fades off to about 20% in adulthood. So how much sleep do we really need? And again, that changes over time. Newborns spend about 2/3 of their time in sleep, whereas infants spend over half the day in sleep, toddlers about half the day in sleep, and then when we get to the teenage years, we kind of level out at about 8 to 9 hours of sleep nightly. Obviously, we don't all get the sleep that we would want to have, but these are the optimal levels that are recommended. The impact of sleep deprivation can be quite severe, both physically and, again, emotionally and mentally. There are a number of studies that have documented that sleep deprivation results in a lower stress threshold. People are not able to cope as well. Certainly, we also know that individuals can't concentrate as well when they're sleep deprived. They don't remember things as efficiently as they would otherwise. Certainly, also, there have been some studies that have shown that sociability and optimism about life is decreased with inadequate sleep. And that's particularly important for the population that we're talking about, children with autism spectrum disorders, because that is one of their chief difficulties to begin with. As we mentioned before, there can be impaired creativity as well. You're not as innovative when you don't get adequate sleep. The physical ramifications include increased resting blood pressure, also increased food consumption and appetite. One of the recommendations to dieters is to get adequate sleep so you don't have that craving for food. And certainly an increased risk for heart problems and even cardiac mortality is associated with insufficient sleep. Let's talk a little bit about sleep disturbances. We know that sleep disturbances are common, certainly even in the general population. It's been estimated the prevalence of sleep disorders in children ranges from about 20 to 30%. These problems are often transient and often treatable through behavioral measures. Probably the most common of the sleep disorders are difficulty falling asleep, waking during the night, the types of insomnia that we're going to talk more about in just a minute. But certainly there can be others as well, especially in different ages of children. Night terrors can be fairly common. Sleepwalking and obstructive sleep apnea are other more medically based disorders. Looking at the prevalence of sleep problems in autism spectrum disorders, we can see that there is a significantly higher prevalence of sleep problems in autism. The estimates that we have come from a variety of studies that have surveyed parents of children with autism. So these are probably not precise measures, but certainly they are much higher than the general population. And interestingly enough, they also seem to be significantly higher than for children with other types of developmental disabilities, whether that's ADHD or learning problems or intellectual disability. Sleep problems in autism spectrum disorders in the past studies have not shown to be significantly impacted by cognitive abilities. In other words, children with autism spectrum disorders who have average or above average intelligence seem to have just as many sleep problems as those with intellectual disability. And in fact, there was a recent study that came out of the Autism Treatment Network and actually indicated that individuals with higher functioning autism, in this case they used Asperger's under the DSM-4 subcategories, actually had more sleep problems perhaps than other individuals on the autism spectrum. There does seem to be some correlation of sleep problems in ASD with increased aggression, certainly with anxiety, and also with that history of developmental regression that we sometimes get. In about a third of cases of children with autism spectrum disorders, we get a history that perhaps they seem to be typically developing speech at about a year, and then perhaps at 18 to 22 months seem to lose many of the words they have and become less sociable. And those children who have that history of regression do seem to have more difficulty with sleep problems. We certainly don't have all the answers as to why children with ASD have more sleep problems, but some clues may be found in the neurobiology that we know plays a part in autism spectrum disorder. As I know you all are very well aware, there's lots and lots of research going on as to the etiology of autism spectrum disorders. And it seems to become more and more complex as more and more research is done. But suffice it to say, there does seem to be a very complex interaction of both genetic and environmental factors. Some of the genes that predispose to autism have been found to be neural connective genes. And these are genes that help with neural synapses. And some of these neural transmitters are implicated in sleep disorders. The three main neurotransmitters are gamma aminobutyric acid, or GABA, serotonin, and melatonin. And it has been found that the genes that we talked about that are neural connective genes and have been implicated in ASD are genes that influence the release of GABA at various synapses. Serotonin is another neurotransmitter that plays a role in sleep, and it's a precursor to melatonin. And there have been studies that have shown that the platelet serotonin levels are decreased in children with autism spectrum disorders as compared to typically developing peers. Another finding that is of interest is that children with ASD seem to have reduced GABA receptors in certain parts of the brain. And these are parts of the brain that play a role in facial recognition and also of interpretation of social emotional cues. So there is some evidence that there is a connection here that might explain in part some of the increased difficulties with sleep problems. And certainly we know that melatonin is a natural hormone that helps regulate the sleep-wake cycle. And there's some evidence that either melatonin secretion is reduced in children with ASD, or that the timing of the release of melatonin may be different in children with ASD. So we'll talk just a little bit more about the role of sleep in learning. We've talked about it with regard to emotional self-regulation and physical well-being, but I think it's also important to note that it plays a very significant role in learning. There's lots of evidence that sleep allows us to retain learning tasks. It allows an event to be encoded and then committed to long-term memory. This is particularly true for procedural activities which involve sequenced tasks. Slow wave sleep, or the non-REM sleep that we were talking about before, is critical in this type of memory. On the other hand, REM sleep seems to be important to retaining memories that involve an emotional component. So memories of a happy or sad event or a fearful moment in a child's life. The REM sleep allows the child to make sense of this and to decipher how that is important in the child's life. This is a picture again of the different stages of sleep. And I think, again, it's just important to keep in mind that if individuals with autism spectrum disorders have a decreased amount of that REM sleep that's important for social emotional memory, this could go back and forth. It may be a causative factor or it may be a result of the lack of sleep, but obviously it probably plays a role in those social communication difficulties that are so that define autism spectrum disorders. Specifically, with regard to autism spectrum disorders, it's important to realize that sleep disturbances are significantly associated with increased parental stress levels. I think that's pretty obvious why that would be. If children aren't sleeping, parents aren't sleeping, again, that lack of sleep plays a role in negativity and an inability to cope. So it's kind of a vicious cycle. In the general population, sleep problems have been found to be associated with behavioral issues, particularly with problems like inattention and hyperactivity. In ASD in particular, the studies have shown that it is very well correlated with increased repetitive behaviors and insistence on sameness. And again, I think that makes sense. If you're not as able to cope, you're not as sociable, you're not as positive about things, you are going to insist on that routine even more. Short sleep duration has also been associated with higher autism severity scores and more significant social skills deficits. A recent study from the Autism Treatment Network, and this was a study that looked at a significant number of children. In the past, many of our studies have only been with 20 or 25 children, but this looked at 3,500 children with autism spectrum disorders. And they looked at those children who both had sleep problems and those who did not have sleep problems. And they got a couple of measures on those children. One was the child behavior checklist, and the other was the Vineland scale of adaptive behavior. And the child behavior checklist looks at both externalizing behaviors, that is impulse control difficulties, aggression, oppositionality, those outward directed behaviors, and internalizing behaviors such as anxiety or depression. And they found that children with autism spectrum disorders who had sleep disorders scored much higher on both the externalizing and the internalizing subtests of the child behavior checklist as compared to those children who did not have sleep problems. There also seemed to be some impact on adaptive or self-care skills as measured by the Vineland, especially with those children who had more moderate to severe sleep disorders. So now we'll talk a little bit about the types of sleep disorder and disorders in autism spectrum disorders. And certainly the most common type is insomnia. And that includes difficulty falling asleep, staying asleep, and early wakenings. It really is important to look at any medical conditions that might contribute to insomnia as a first step. And certainly there are a number of these that children with ASD seem to be predisposed to. Many children have GI concerns, whether it might be gastroesophageal reflux disease, constipation, or stomach pain due to other problems. Certainly some medications can also play a role. There are certain anti-epileptic medications such as lamotrigine, which are known to have this effect. Stimulants that are used to treat ADHD symptoms are also pretty well known for having an impact sometimes on sleep, particularly as they wear off and there is a kind of rebound high activity level. Some antidepressants can also cause insomnia. Usually they tend to cause more sedation, but either insomnia or sedation, depending on the individual, can be seen with those. We also need to look at comorbid conditions that might contribute to sleep problems. Many children with autism also have attention and impulse control difficulties and meet criteria for attention deficit hyperactivity disorder. Children with ADHD are somewhat notorious for having problems settling down to sleep at night due to their hyperactive and impulsive behavior. Youngsters who have significant anxiety, fears, and worries, whether it's fear of the dark or fear of being alone or fear of what's going to happen the next day at school, that make it very difficult to fall asleep at night. Sometimes kids get into a behavior pattern that contributes to insomnia. They get up repeatedly because it gets them attention, and they would much rather be up and doing something they enjoy rather than going to sleep. Limited communication skills can certainly play a role, particularly for children with ASD. If a child can't communicate his feelings or fear, it makes it really hard to be able to establish a bedtime routine. And in the same vein, if parents can't communicate with their child what their expectations are as far as the bedtime routine and staying in bed, this may make it much more difficult to set up a routine where the child is going to bed in a timely fashion. Another sleep problem that can be seen in children with ASD is obstructive sleep apnea. And obstructive sleep apnea is caused by airway obstruction that results in disrupted breathing during sleep. Often this will be characterized by loud snoring, perhaps followed by a few seconds where the child stops breathing altogether and then restarts breathing. A very common cause for this in children tends to be enlarged tonsils and adenoids. Other causes may be obesity or hypotonia. And hypotonia kind of refers to lower muscle tone. If there's not good tone, there may be obstruction between the oral and nasal cavities that contribute to snoring. And this tends to be pretty common in kids with autism spectrum disorders. There really does seem to be a very strong link between obstructive sleep apnea and inattention. And in fact, there have been studies of children who have been diagnosed with both ADHD and obstructive sleep apnea, who once they were appropriately treated medically, no longer met criteria for ADHD. So it's certainly a consideration and a question to ask in children who present with attention and impulse control difficulties. Parasomnias are another type of sleep disorder, and at least a few studies have indicated that parasomnias may be more common in autism spectrum disorders than they are in the typical population. Parasomnias often occur during the first half of the night and during non-REM deep sleep. Some of the parasomnias include night terrors, sleepwalking, and confusional arousals. Night terrors are characterized by the child waking up screaming and non-consolable. Often these episodes last about 15 minutes, and the child is very difficult to comfort during that time and generally has no memory of the event the next day. Confusional waking occurs when the child wakes up and is quite disoriented, has difficulty answering questions, and seems very unaware of their environment. Sleepwalking usually involves children walking around with their eyes open, although the eyes may appear somewhat glassy. During sleepwalking episodes, sometimes children can do things like moving furniture or urinating in unusual places. It's generally thought that it's fine to wake the child up, but probably not appropriate to restrain the child during sleepwalking. There are also some parasomnias that occur during REM sleep, and those are generally nightmares. Movement disorders can also be seen in children with ASD, as well as typically developing children. And among the more common movement disorders are restless leg syndrome. And that's characterized by the need or urge to move the legs, and it usually occurs right at bedtime and is relieved by movement. But obviously it can be a very strong contributing factor to insomnia if you have to move around in order to prevent this urge. Periodic limb movements occur during sleep, and they're characterized by repetitive, stereotypic movements of the limbs, and that occurs again during sleep. Interestingly enough, restless leg syndrome has been found to be associated, at least in some cases, with low ferritin or iron levels. And so when that is diagnosed, typically the clinician will get a ferritin level, and if it's low, certainly supplement the child with iron, and often that causes some relief of that particular disorder. So how do we diagnose sleep disorders? And the most important means is through a good history. And I want to make the point now that more and more information is becoming available on sleep disorders in autism. And in fact, there was a statement a couple of years ago that came out in the Journal of Pediatrics requesting that pediatricians and other primary care practitioners screen routinely for sleep disorders in their patients with autism. So I think we are getting the word out that this is something that it's very important to look at, and especially in this population. So what do we want to find out about sleep? First, you want to find out when bedtime is, and how long does it take the child to fall asleep once he's been put to bed. You also want to find out the activities preceding bedtime. Is there a bedtime routine that's established? How much sleep does the child actually get? Is there daytime sleepiness, or is there napping during the daytime? Does the child wake up refreshed, or does he have to be dragged out of bed every morning? What is the child's attention and mood like during the day? Is there technology available in the room at night? Does the child wake during the night? And if he does waken during the night, can he fall right back to sleep, or is he up for the rest of the night? You also want to find out about any parasomnias or snoring, just as we talked about. That can indicate, certainly the snoring, some medically treatable condition that needs to be addressed. Does the child seem to have significant anxiety or depression? Is he going over the events of the day in his mind, and that keeps him from falling asleep at night? Is there a change in the sleep pattern? Was he really sleeping well for quite some time, and all of a sudden he's no longer sleeping well? Maybe that indicates some kind of medical condition or emotional change that needs to be addressed. And what are the child's medications? As we mentioned before, there are some medications that can contribute to insomnia, so you want to be sure that that is not an issue. Questionnaires can also be helpful, and probably one of the most useful is the Children's Sleep Habits Questionnaire. And that consists of 35 items that parents fill out, and it's for ages 4 to 10. And basically it consists of a number of statements about sleep. And the parent is asked to categorize the statement as always, sometimes, rarely, or never. So one statement might be, the child falls asleep within 20 minutes of going to bed. And then parent says, always, rarely, or never. Or the child goes to bed at the same time every night. Or the child sleeps by himself. So that gives you a good idea of exactly what goes around, what is going on around the sleep process, and can give some really good information. The family inventory of sleep habits can be helpful too, because it looks at the family pattern of sleep. There's nothing wrong with co-sleeping if that is part of the family's culture and so on. The only time it becomes a problem is if that child is totally dependent on the parent being there during the night in order to fall back to sleep. So that can be an issue in some cases. The pediatric daytime sleepiness scale can also be helpful, again, looking at the child's energy level and whether it appears that he has adequate sleep. The child behavior checklist is actually not a sleep questionnaire, but as we mentioned previously, it is a measure of a variety of behaviors, including attention, depression, aggression, oppositionality, and so on. And it can be a helpful measure to look for any comorbid conditions, but also to look at the potential impact of sleep deprivation. Sleep diaries can also be helpful. And basically, that helps you keep track of the times that the child goes to bed, the time the child falls asleep, the time the child wakes up during the night, and wakes up in the morning. And it allows you to establish a pattern of sleep habits. Not only is it helpful in the initial diagnosis, but it can also be helpful in demonstrating response to treatment. If the child's going to bed at an earlier time and having few nighttime awakenings, that indicates real progress. A more objective measure of measuring sleep is actigraphy. And this involves the use of a portable device. It's usually kind of a wristband similar to a wristwatch, and it requires movement over extended periods of time. So you can really get an idea of the times that the child is actually asleep and moving much less, and the times that he is awake. And again, it can give you a more objective indication of how much time that child actually spends sleeping, and to characterize the circadian rhythms for that particular child. Again, that can also be helpful for determining response to treatment. Polysomnography is really the gold standard objective way of diagnosing sleep disorders. And it's an overnight study that looks at a variety of factors that occur during sleep, including brainwave activity. It's actually an EEG recording, oxygen level, heart rate, breathing, and eye and leg movements. It is not a painful procedure, but it can be often difficult, especially for children with autism spectrum disorders, because it does involve electrodes and other devices on the body. Many kids with autism spectrum disorders also have difficulty in a new environment, so you may not get the best measure of sleep in a strange place that the child is not used to overnight. But it really is extremely helpful, particularly for diagnosing those conditions that may have a medical component, such as obstructive sleep apnea or nighttime seizures. So now we get to the treatment of sleep disorders. And I want to make the point that really it is essential to treat any medical problems that might be causing sleep disruption. We talked about obstructive sleep apnea, and I think this is an obvious one. If the child has obstructive sleep apnea, then you certainly need to refer that child to an ear, nose, and throat doctor to look at the possibility of doing a tonsillectomy and adenoidectomy. Weight loss may be helpful in many cases to reduce obstructive sleep apnea. In addition, positioning the child in an upright position during sleep can be helpful at times. Certainly with adults, the primary treatment is continuous positive air pressure, and that involves a device being placed over the face that will help keep the airway open. It may also be helpful for many children with ASD, but many times it's not well tolerated in that population. We also mentioned restless leg syndrome, the possibility of treating that with iron supplements, so that's certainly something to look at as well. As we know, seizures are more common in children and adults with autism spectrum disorders, and in fact, up to a third of individuals may have seizures at some point in their lives. So it's extremely important to keep those seizures under as good control as you possibly can, to have that child seen by the neurologist, and to develop the medication protocol that's going to be most effective. Certainly gastrointestinal problems, whether it's constipation or gastroesophageal reflux disease or whatever, can be a significant cause for sleep disruption. So you want to be sure that you're addressing some of those concerns. With GERD, while it may be hard for many kids with ASD to let you know whether they've got pain associated with reflux, you may have to look at the signs, after eating. Is there some discomfort or lots of burping or that sort of thing? And then you may want to try give a trial to an acid blocker or a proton pump inhibitor to look at that. Certainly dental problems can be another issue, and again, that's often very difficult because many kids with ASD don't tolerate dental procedures, even cleanings, very well. But really it's important to get in touch with a good dentist who works well with kids with developmental disabilities, and to be sure that that's not something we're missing. Even eczema with marked skin itchiness or asthma exacerbations that are poorly controlled, coughing or wheezing during the night, those can all be causes for insomnia or disrupted sleep. Mood disorders, certainly we've talked about that before. Children who are fearful or who are depressed, who have changes in their sleep patterns, whether it's oversleeping or undersleeping, need to be looked at and evaluated and given appropriate treatment. And often that involves some form of cognitive behavior therapy and or medication. Another aspect of treatment is certainly implementation of healthy sleep practices. And that involves not only a bedtime routine, but also really looking at daytime practices. We talked about the fact that many children with ASD seem to have disruptions in their circadian rhythms. So it's really essential that they receive adequate exposure to light during the day. You most likely want to restrict caffeine intake, and you want to be sure that there's plenty of exercise and release of energy during the day. Trying to minimize naps. Certainly naps after 4 p.m. will probably be detrimental to falling asleep at night. It's also recommended that you use the bedroom primarily for sleep. Not all daytime play activities, but primarily that is the role for the bedroom, is for sleep only. And that can set that pattern in the mind of the child that this is the place that I go to sleep. When you're looking at evening habits, you want to have wind-down activities that are not highly stimulating. So that might involve reading a story, or if a bath is relaxing and not stimulating for a child, then you might go with that. You don't want to do roughhousing or wrestling shortly before bedtime because the child is all wound up. Some parents and other professionals have suggested massage or relaxation techniques prior to bedtime. While a cool, dark room is usually recommended, you have to individualize that because there are some cases where it may actually be helpful to have a little bit of white noise in the room to block out background noise. Or for children who are fearful of the dark, you certainly may need a night light in the room. In almost all instances, you want to eliminate electronics. TV, video games are highly motivating to children. So it interferes with their falling asleep, and then if they do happen to wake up during the night, they're highly motivated to go back to the electronics rather than falling asleep. Everybody wakes during the night, but we have to find our own techniques for falling back to sleep. You will most likely do not want to have a heavy meal just before bedtime, but certainly a light snack can also be helpful in some cases. Some parents have found that a weighted blanket is of benefit. That feeling, that weight helps perhaps calm their child, gives that needed sensory input, and helps the child settle down to sleep. Interesting, I just read a recent article that looked at weighted blanket use in Great Britain, and they actually did a controlled study of 2 weeks with a weighted blanket versus 2 weeks of a regular blanket as the placebo, and actually found that the total sleep time did not vary significantly from one intervention to the other. However, parents really liked the weighted blanket and felt that sleep was better for those kids who were using the weighted blanket. So the jury's still out on that, but you know, that is something to consider in individual cases. You also want to establish a bedtime routine. And the bedtime routine should probably be about 15 to 30 minutes in length, and certainly no longer than an hour. And whatever routine you decide on, you want to be consistent with it. So it's the same routine every night. Often visual schedules can be very helpful for kids with ASD to help establish that routine. So you have your pictures of exactly what's going to happen in the bedtime routine. If the child takes longer than an hour to fall asleep, you may actually want to move bedtime back for about 30 to 60 minutes so that the bedtime routine corresponds with his actual sleep pattern. And then you can gradually move the bedtime routine a little bit earlier each night. And sometimes that can be quite effective as well. As far as the treatments, and we mentioned the visual schedule. There are also a number of social stories about sleep, and there's actually one by Carol Gray called The Last Bedtime Story, and in parentheses, that we read every night. And for some children, that can be very helpful in establishing a bedtime routine. There are also a number of free social stories. I Googled social stories about sleep and ASD and came out with a number of them, which possibly might be helpful as well. For many, I wanted to just touch for a minute about the importance of being able to fall back to sleep. We mentioned that just a minute ago, and as we're talking about, it is something that routinely happens for us all during sleep. Sometimes we never remember that we woke up and we're able to put ourselves back to sleep, but that's not always the case for children with ASD. And certainly I hear all the time that once the child wakes up, they cannot go back to sleep. And sometimes having the child who's dependent on the parent falling asleep with him, that will be an issue. So the child feels that that parent has to be there in order for the child to put himself back to sleep, and can't develop any strategies on his own to do that. And how do you handle that? It's very difficult in many instances. With young children and infants, sometimes the best approach may be a cold turkey approach. So you settle the child in for bed at night, sure that all his needs are met, and then just leave the room. And the child's going to cry, and it's going to be hard, but you do that over a few nights, and gradually the crying diminishes and the child learns that he can fall asleep on his own. With older children, it may be a lot harder. I think no parent wants to feel that their child is suffering because he or she can't fall asleep, and they obviously become more upset when there is no response to their crying. So in those cases, you may want to take a little bit more gradual approach. So perhaps instead of lying down beside the child for him to fall asleep, maybe you just sit in the bed beside the child, and then gradually over a few nights sit in the chair beside the child, and then move the chair eventually halfway across the room, and then to the door, and so on. And during this routine, you want to not give the child a lot of attention. You don't want to give a lot of visual eye contact. You don't want to pay them a lot of attention. And if the child wakes up, you go into the room, you pat the child on the back and use some kind of phrase like, "It's okay, time to go back to sleep," and then just make that part of your routine and fade out the child's need for you to be there. Sometimes bedtime passes can be very helpful for kids who really have a hard time settling down to sleep. So the bedtime pass idea is that they get, it can be a picture, it can be a written bedtime pass, but they get one time to use the bathroom or get a hug or get a drink, whatever they want to use it for. And that's it. After that, no more bedtime passes. And if the child doesn't use the pass, then you could tie it to some kind of reward in the morning. You know what? You went right back to sleep. You went right to bed. We didn't even need to use the bedtime pass. You're going to get to do this with mom today, or something that is rewarding for that child. I wanted to show you an example of one of the visual schedules. This came from the Autism Treatment Network guide regarding sleep problems in ASD. And I think it's nice. Again, it can be real pictures, it can be drawn pictures of whatever, just whatever works for that child. But it gives the idea of what the routine is, and can be simple, and makes it clear what the expectations are. If behavioral strategies alone don't work, consideration may be given to a trial of melatonin. We talked about melatonin being a natural hormone, a neurotransmitter that has an important role in sleep and that helps regulate the sleep-wake cycle. There's also actually been a meta-analysis of studies of children with intellectual disability which found melatonin to be safe and effective. And there's been a retrospective study of about 107 children with autism spectrum disorders, which also found it to be effective, particularly with sleep onset and total sleep time. Now, melatonin is over-the-counter, and for that reason is not FDA, and it's considered a supplement, and it's not FDA regulated. So you probably want to ask the pharmacist about a reliable company, no additives to the melatonin. It certainly seems to be safe in the short term. There doesn't seem to be a lot in the way of side effects. We don't have any long-term studies at this point. It comes in a short-acting form and also an extended-release form. And the short-acting form, again, is probably particularly helpful for children who have difficulties falling asleep at night. And you generally give the melatonin about 30 minutes before the expected bedtime. There's an extended release form, and sometimes it can be helpful to combine the two. If the child's having difficulty both with sleep onset and with sustained sleep, you might want to use a combination of the two forms of melatonin to help sustain sleep. When it's effective, it can be extremely effective. Generally, I'll start at about 1 milligram, 1.5 milligrams, half of a 3 milligram, and then every few days go up a milligram until we get to a point where it's effective. I think if you've gotten to 10 milligrams and it's not working, probably it's not going to be effective. There are also other medications that have been used for sleep in children with ASD, and the difficulty here is that unfortunately there's not been a lot of studies done on these. But clonidine is an alpha agonist. It's used for hypertension and also used for ADHD symptoms, and it's primarily used because it has a fairly strong sedative side effect and can be helpful with sleep onset. There actually is one study that did find that it was helpful in children with ASD. It was a retrospective study and not a large study, but that is available. There are also other medications, and there are a couple of antidepressants, trazodone and mirtazapine, that are often used for sleep onset. They're not probably so good as antidepressants, but again, because of strong sedative side effects, they can sometimes be effective. Obviously, you would need to talk with your physician about any of these medications. There are 2 FDA-approved atypical antipsychotics that are used for marked irritability associated with autism spectrum disorders, and these are aripiprazole and risperidone. I don't use those for sleep alone, but for children who have an indication for those medications because of outbursts, aggression, self-injurious behavior, then sometimes those medications can also help with sleep as well. I wanted to point out a few resources that you might want to look at. Certainly, one nice one is the Autism Speaks Toolkit, and it's termed Strategies to Improve Sleep in Children with Autism Spectrum Disorders. And it includes many of the suggestions that we've talked about today. It gives examples of visual schedules, and it's just a nice guide. It's freely downloadable, and I think if you Google that, you will find it without any problem. I also found a couple of other resources. There was one that came from the United Kingdom called Sleep and Autism, Helping Your Child. And you might want to look at that one too. There are a few suggestions there that are not in the Autism Speaks and vice versa. There was another one called Establishing Positive Sleep Patterns for Children on the Autism Spectrum that you also might want to be aware of. This is the cover for that ATN Parents Guide that we were just talking about. So we're at the conclusion of the presentation, and I just wanted to briefly go over that sleep problems, as we've talked about, are very common in children with autism spectrum disorders, insomnia being the most common, but there are certainly other types as well. We diagnose through a detailed history, sleep diaries, and questionnaires can be helpful. We also talked about polysomnography and actigraphy, which can be helpful measures. And then our primary treatments are medical treatment of the sleep-disrupting conditions, establishing appropriate sleep practices, providing behavioral interventions that are going to be helpful, and then in some instances, melatonin or other medications may be necessary. So thank you so much for your attention. I've very much enjoyed this, and I'll turn it back to Denise.
Okay, thank you so much for your presentation. We've got a number of questions here. Melatonin hasn't been effective for us, and on the advisement of our health professionals, we're taking their advice not to use it long term. We are trying 5-HTP, so it's too early to report on whether that would help us. It's only been a few nights, but the last 3 nights were restful. We had a sleep study done overnight, but it didn't reveal anything as I hoped it would. Why does autism bring these disorders on, and are other supplements sometimes helpful?
Well, you know, as we talked about, it's a great question, and I'm sorry melatonin was not helpful. I think that, as we've talked about, there are a number of issues that probably play a role in sleep problems related to autism. One being some of these neurochemical issues that we've talked about with the neurotransmitters and the circadian rhythms. I think part of it, too, is just the underlying deficits in autism, that those social communication deficits and insistence on sameness and so on. I haven't seen any studies about serotonin or 5-HTP. I mean, I think it makes sense that it might be helpful, but that is one that I have not used by itself. You know, it is supposed to be the precursor of melatonin, so again, it might make sense that it would be of help, but I just don't have enough information about that to say, I'm glad you're seeing some relief, but certainly I think I would talk with the sleep specialist again, because if nothing medically or medically treatable turned up in that, I think it's still important that you assure that your child gets a good night's sleep and talk about other options. And sometimes that does involve medication or other supplements, but really the best studied one has been melatonin.
Okay, great. The next question is about referrals. This parent is saying, where do we go to have a child evaluated for sleep disorders? My physician has never mentioned such an option. How would I advocate for that?
Well, that's another really good question. We have a pediatric sleep specialist here, and that is generally who I start with. I think any fairly large city who has an academic center will or should have access to a sleep specialist. I think I'd start by talking with your pediatrician and discuss the fact that you heard a presentation, discuss the child's sleep problems, what interventions you've already tried, and that type of thing. But I will say that, you know, general pediatricians can't be familiar with everything. So I would just talk with my pediatrician and say, I'd really like to get this looked into. I've tried a number of things. I'm worried that there might be something going on that I don't have a good handle on. But pediatric sleep specialists are becoming more and more available. And again, what they will start with is a detailed sleep history. And then sometimes that's all there is to it. Sometimes they'll suggest some some behavioral interventions or that. Other times they may go that extra step and do the polysomnography, particularly if they suspect something like obstructive sleep apnea. And then you get, a detailed report, and it gives you some additional information. So I absolutely think, as I mentioned, if you feel like you need a backup, there is that nice article in Pediatrics from 2012 that gives you kind of a sleep algorithm, especially for kids with ASD, or go to the Autism Treatment Network and get some of their information, both the brochures, and they've got some general information, and just take it to my pediatrician and say, I'm really concerned about this, and who can we go to? But I think you can find sleep specialists on your own, but hopefully your pediatrician will be aware and just has not been tuned into that.
It sounds like you've worked with quite a few parents. The ones that you have seen be successful with consistency in sleep patterns, what was their secret?
And I'm laughing because that's it. It's just a consistency, and I know that is so entirely not easy, especially when you're at your last nerve and you just say, I just need some sleep, and you say, I'll just lie down beside the child this one time. Unfortunately, that's the way it is, I think, with any of these behavioral interventions. The consistency is so important. It is with all kids, typically developing kids and that type of thing. That one time that you don't follow through, that's the time they remember, and they kind of escalate the next time around. And I don't know what the secret is. I wish I really did. I think it's trying to look at that long-term goal that, yes, I'm going to go through a few nights of hell, but in the long term, it's going to allow this child to sleep through the night. And the other thing is, give yourself a break. I knew a psychologist, and she actually worked with kids with ASD with sleep, and she said, my solution was, I let my husband do it. He was the one that was going to take care, because he knew that I couldn't stand listening to the child cry. So maybe you build in some supports too for those times that you feel that you're ready to give in. I wish I had a better answer than that, but there unfortunately is no easy answer.
Okay, this parent is asking about melatonin, looks like sublingual versus taking capsules. They're asking if there's any difference between taking it sublingually and taking capsules, or if there's any reason you would differentiate.
I don't think so. There's a liquid form as well, and and I've had some parents do that. Generally, the tablets are the least expensive and the most widely available, and so on. The sublingual probably should be a very immediate release. I don't know if its onset is any faster than the tablet, but I suspect, the tablet has pretty quick onset within about 30 minutes, so it might be a slightly more rapid delivery system, but other than that, no, I don't think there's going to be any significant difference.
Okay, this parent's asking, it sounds like they have a young child who is they're mentioning a medication called Keppra. I don't know if that's anything you've heard of.
Keppra is an anti-epileptic medication. And I'm assuming it's probably being used for seizures.
Yes, it says here, this child had a negative reaction to Keppra, though, and had trouble with aggression, and now they're having trouble getting back into good sleep hygiene habits. Do you have any suggestions? Have you ever seen a patient who had an experience like that and then it was difficult to get them back on track?
It is hard. Yeah, and Keppra, it's good medication, but it can have some behavioral side effects, and it's good that you all recognize that and got off the medication. It is often hard to reinstate good sleep habits, and I don't know. Obviously, you and I'm not sure how old the child is and that sort of thing, but I think you go with the behavioral interventions first, just what we were talking about, and you may have to go back a few steps and do all the supports around surrounding sleep hygiene. I would say, if that is not working and this child has not been tried on melatonin, I might try melatonin just on a temporary basis to see if it had an effect, and then you can wean off it as soon as you get back into that good sleep pattern. Again, on a short-term basis, I think it's pretty benign, and I've used it in some of those situations where maybe there's a stressful event going on or something of that sort, just on a short-term basis, and then you can get off it again. I guess those would be my primary suggestions.
Okay, great. Here's a good question. They're asking about bedwetting past age 10. They're asking, has it been found to be a fairly common problem past age 10 in autism? My friend's son is 13 and still has the problem. He's been given medicine, but it still happens now every day. Liquids are avoided a few hours before bedtime. An alarm is set to wake him at 1:30 so he can get up and use the restroom. But he's been to a urologist and they found nothing wrong. What else might they do to help him?
Well, it sounds like they've done all the right things, that's for sure. I will say it is fairly common. I think bedwetting is kind of a developmental process, and a lot of times in typically developing kids, it's not, it's after the age of 6 that you would typically expect it to not be an issue, but everybody's different. Sometimes bedwetting tends to run in families, so there are a lot of issues that occur surrounding bedwetting. Again, I think it sounds as if you've done just all the right things. You're being sure that they're not drinking much after dinner. Void, and that bedtime alarm is supposed to be probably the first line. You've had him checked out by the urologist so that you're sure that it's not something physiologic. There are other strategies. I think the idea behind the bedtime alarm is that it helps the child learn how to wake themselves, so that they then associate that with the alarm and the urge and so on. I obviously don't know when your child was toilet trained during the day, and sometimes, again, it can be a developmental process. The other things that you might sometimes tying it to a reward during the next morning. If they stay dry, we're going to do something. It probably needs to be a fairly immediate reward. And I would actually let the child start taking responsibility for cleaning up after. It's not a punishment. It's just a natural consequence. You wet the bed, so you help me pull the sheets off and put them in the laundry. There is also a medication called DDAVP, which kind of helps dry things out. It's probably more a temporary solution than it is a long-term solution, but you could also ask your pediatrician about that. Again, I have no criticism whatsoever of what you're doing. Those may just be an additional couple of things to think about.
Okay, so I think we have time for just one or two more.
Okay.
There was a question here. This parent said that melatonin was really effective for their child until puberty. And they're wondering, have you ever seen an increase in severity of sleep issues as people on the spectrum age? Have you observed anything along those lines?
Well, that is a good question. I guess I see more frequently, the fairly early onset of sleep problems and kind of continuation. And sometimes they actually get better. But puberty is a real hard time. I've certainly seen kids who have had an increase in behavioral issues during that time. Also some sleep. I guess it's not so unexpected. Certainly teenagers in general seem to have more sleep, or at least resistance to falling asleep during the, so yeah, I've seen it. I guess I've not seen it as much as the other, where they're just kind of ongoing and sometimes improve. But yeah, that would certainly, and I guess it would not unexpected given the hormonal changes and so on. I wish it's nice when melatonin continues to be effective throughout. But the hope is that even though you're seeing more in the way of sleep problems, your youngster's understanding more about the sleep routine and at least some of the rules. So even if he's not falling asleep, staying in bed, not getting up during the night, and kind of helping to reestablish that pattern. And I do think there's some role to, and again, not knowing this teenager, but being sure that there is enough activity during the day. Sometimes kids get so stuck on technology that they perhaps don't burn up that energy. And then the other thing is looking at, is there something else going on there perhaps? Is there now some anxiety or other issues that need to be looked at?
Okay, great. One last question. We live in a community. Okay. We live in a community where behavioral interventions that include some form of crying, even controlled or with your presence in the room, is not readily accepted. Do you have any evidence-based research on normal stress with crying versus crying that causes emotional trauma? How can we ease patients or parents' conscience about this? So I think they're talking about the idea of letting the kids cry, to go to sleep.
Yeah. I think that's a good question. And again, I think you. And I wish I knew of some evidence-based practices. I mean, kids cry, and it's their way of expressing themselves that they're unhappy and so on. But I think crying in and of itself does not cause emotional trauma. And I think you just help parents maybe look at the big picture. We all go through some trying times, but we learn from those. We learn from our experiences, and obviously you don't want to do anything harmful for a child, but if it's a part of a natural learning process, then it's probably okay. Again, in young children, and I know there are a lot of families that even with infants just can't stand to hear them cry. It's perfectly fine to reassure yourself that child is fine. There's nothing wrong. We know all the needs are met and so on. And to look at, I'm just going to remove myself from the situation. It's the same as, when child's throwing a temper tantrum or something of that. I don't think you're doing them any favors by going over immediately and giving them attention for that, because it reinforces the fact that this temper tantrum is getting me what I want, and I'm going to do it some more. So I guess I would try and work with the family on getting the big picture, that this is going to result in better sleep in the long run. And if we don't want to do it with, this child crying for extended periods of time, we use that more gradual approach, so that we know it's okay. There are instances where parents should remove themselves and not address that. I think that's the difficulty when kids are acting out and parents get so totally frustrated, that's the time that they probably should remove themselves as long as the child's in a safe place and so on. So I guess that would be, my thought, that you try and look at the long-term goal, that this is not going to be emotionally harmful, and in fact is, I don't have studies to quote you on that, but I think we feel very comfortable from the sleep specialists who have reported these various techniques that it doesn't result in long-term harm, and it can be for the child and the family's benefit in the long run, because everybody is on a more even keel and able to cope better if the child gets adequate sleep.